Good evening, everyone. My name is Kathy Sullivan. I'm the Director of Professional Development at Hill Learning Center in Durham, North Carolina. Thank you so much for joining us to kick off our community education series for 2023. For those not familiar with Hill, we're a K-12 education nonprofit that exists because mainstream instructional practices too often don't serve all students, including those with both diagnosed and undiagnosed learning differences. Our ambitious vision is that all students with learning and attention challenges receive the instruction and support they need, regardless of where they attend school. We pursue this vision through a range of student and educator programs and professional development efforts that reach students and educators here in Durham and beyond. If you haven't already, I encourage you to visit our website and explore the available resources at hillcenter.org. Through our community education series, we offer free, practical, research-based strategies to help students, as well as the parents, teachers, and professionals who support them. So thank you all for being here. Before I introduce our presenter tonight, let me cover a few details. This evening's event is being recorded, and we will send that out to registered participants tomorrow, along with a copy of the slides and a short survey. I ask you please to complete the survey. We read every piece of feedback we get, and it's important to us in developing future sessions. All participants are muted, but you can submit questions and comments to the presenter and the team here at Hill anytime using chat. We will use those questions for the Q&A with Dr. Kahn at the end, so please send them in the chat as you have them. Dr. Kahn's going to present for a little less than an hour or so, and then we're going to have that Q&A. So we'll be collecting the questions, send them in the chat as you have them. And now it's my distinct pleasure to welcome Dr. Andrew Kahn. Dr. Kahn is a licensed psychologist specializing in working with individuals who think and learn differently. In his role at Understood, Dr. Kahn focuses on ADHD, autism spectrum disorders, anxiety, general learning and behavioral challenges, and learning and social emotional functioning. For nearly 20 years, Dr. Kahn worked within the public school system, providing training, evaluations, consultation, and therapeutic support to students, their families, and staff. Prior to joining Understood, Dr. Kahn served as a presenter for Summit Professional Education on ADHD, autism, and anxiety for nearly 10 years. He was also an educator at the University of Maine. He earned his bachelor's degree in psychology from Syracuse University and both master's and doctoral degrees from Nova Southeastern University. Dr. Kahn personally identifies as a person with learning and thinking differences. He speaks to you tonight from both experience and expertise. So it's my pleasure now to turn it over to Dr. Kahn.
Thank you, Kathy. I appreciate that. It's hard listening to a long bio like that.
I know.
The key here is, okay, guys, I've done a lot of stuff.
Yes.
It's good to know this. I really appreciate the opportunity to really sort of chat with you folks tonight. As we talk about something as personal to me as ADHD, it's really important to sort of put into context sort of my work, how my work relates to your lives, your families, your circumstances. And also speaks to the idea of what we do in our day-to-day. As someone who spent so many years in schools, when we talk about having learning and thinking differences myself, I have ADHD. As a guy in his 50s, that means that my ADHD wasn't identified until adulthood. So I have a very, very strong place in my heart and in my experience for thinking about the differences that we see in our kids, in ourselves, and in our communities. So to talk about these topics here today, we're really talking about things that are important, things that a lot of things you're going to know, but a lot of information that I hope you're going to be able to think about a little bit differently. And the reason I have this slide up, it Understood, one of the things that really speaks to me is we talk about shaping the world for difference. As an educator, one of the things for me that's always been really important, and working in the K-12 or pre-K-12 world for so many years, was really hard because I think about all of my clients, my kids, my students, as human beings who are going to be living a whole life. So it isn't just my responsibility as a clinical person to shape their educational experience or to help them graduate, but it's about helping them create a life for themselves to navigate those important moments, to transition from not just going from elementary to middle school or middle school to high school, but going from high school into the world. And we have an obligation as folks with knowledge to try to shape that world to help them not only find their way in it, but to thrive. So for me, that's one of the most important pieces of this. And in being my role at Understood is I work in the behavior change portion of the company, where we're creating content every day to help people develop information, strategies, set communities for one another so that we can help ourselves thrive as kids going through school, as well as the parents of those kids. And I think many of you may have shared the experiences of your children. So these are things that I really take to heart in my work. So let's start a little bit talking about our agenda here today.
Dr. Kahn, if you don't mind, could you check and see that you're sharing this?
Oh,
I
well,
think we might have taken it down when we were
Oh,
preparing.
when we went to practice.
Yep.
Yes. Well, there we go.
All right, cool.
All right,
so
we're
much.
back. That was way too much of my face anyway. Thank heavens that's done. All right. So as I was saying, we're going to go for the agenda here. Agendas as being a lifelong educator and a lifelong learner, it's really important to know where we're going today. And I'll give you a little bit of a caveat. As somebody with ADHD, I apologize. I move a bit in my chair. I have to move a little bit to keep my brain from sort of creeping out of my own head. And in terms of working with our slides, the slides are a guide for me. I'm going to talk around the slides. I'm not going to read off of them for you guys tonight. And keep in mind, for an ADHD brain, 6:37 p.m. is crispy time. This is a time where I'm doing my best to be with you in full form, and I will give you everything I got. But I'm at my most human right now, so I hope you can share some compassion. All right, so the agenda here this evening, we're going to talk a bit about the ADHD myths, the things that we know about ADHD, and some of the myths and stigmas that come into play that really do affect our world and how our kids function and how we find the world in terms of their readiness to help us help our kids. We're going to talk about the role of myths in society and why this is important for accessing the things we need and providing the information, support, and kind environments for our kids and our students. We'll talk about some of the gender differences we see with ADHD, some of the stereotypical, some of the real, and some of the research. And we'll dabble a bit in the treatment options, talking about the information about what do we do and how these relate to the realities of ADHD as a diagnosis itself. If we have questions that come up, obviously the chat is going to be monitored by folks, but we're going to save, the lion's share of our questions for the end of the presentation. So, store up your questions. I'll stay for as long as I reasonably can. And let's go into some of the data here. All right, so talking about some of the common ADHD myths. In isolation, some of these myths are going to sound really silly to some of you folks, but I think providing some context will help you understand that why we go through these myths, why we have these conversations, are about understanding the world that our kids live in. That's going to be extremely important in being compassionate and helpful to them. One of the first myths we talk about is the idea that ADHD isn't a real thing. There are many people who don't believe ADHD is real, that they believe it's an excuse for certain kinds of behavior, that it's an explanation that gives away responsibility. When we talk about a diagnosis, though, the idea here is that ADHD not being real is a barrier. It is something that is used to criticize and to actually take responsibility away from the person working with our young people who have ADHD. If we don't believe something's real, we can use a behavioral explanation and we can start to use blaming terminology. We can start to make assumptions about them that are unfair or untrue. So keeping in mind that the idea that ADHD is an absolute real thing, and not only is it a real thing, but it's something that exists across the person's lifespan. People have to understand that ADHD is a wiring difference. It is about how your neurology processes information that it receives through its senses. And that neurological set of differences results in certain things being more difficult, certain things happening less naturally. So when we think about the idea of ADHD, The primary complaint I heard when I was a student in school was, gosh, that kid just needs to work harder. Seems like a bright enough kid, but he's always sort of off in left field and wool gathering and just if you just buckle down and work harder. And for the longest time, I felt like I was working pretty stinking hard. In fact, kids with ADHD, adults with ADHD, have to work so much harder just to do so many of those day-to-day things that neurotypical or non-identified folks do much almost automatically. If you think about taking away things that you do easily and making it feel like work, you could understand why kids would shut down and why people get so exhausted trying to navigate their environments. The other piece around this that really affected me and affects a lot of my clientele is the idea about how the stereotypes come into play. The idea that if you're not if ADHD should be something I see from a distance. I know what ADHD looks like. And it's really about describing sort of the stereotype, this classically 7-year-old boy out of his chair, pulling hair, jumping around, acting silly, and not being like control of their body. When in actuality, hyperactivity can be an internal symptom. You can be overactive in your brain. You can have difficulty sorting and navigating the huge amount of information that is rolling through your head at any moment in time. And it doesn't have to be something that your body is experiencing in an externally observable way. You're not going to see it with your own eyes necessarily when you look at somebody who has ADHD, unless it's something particularly obvious. One of the pet peeves that really is a challenge too is the idea that ADHD is something that you outgrow. ADHD is someone's neurology. It is how their brains are wired. And that wiring in and of itself, and then let me back up a step. Certainly brains continue to develop throughout life. People can develop new skills and abilities that actually does rewire aspects of the brain. But there are notable changes that we see in the brain of someone with ADHD that are not similar to folks who don't have ADHD. So they're not going to outgrow these differences. The reality is people who have challenges in certain skill areas or in certain areas of functioning as they become adults are going to just choose not to do those things. As a child who struggles sitting down, doing math, and being in a classroom, as an adult, these are things you can avoid. So if those were the areas where you looked most challenged and most unable to function in the way that you felt you should, the idea in adulthood is that it's not that ADHD went away, it's that people self-select environments where they can be successful. So for me, for example, my first job out of graduate school was a traditional clinician in an office. Then I had a combination of child and child and adult clientele. And I struggled most working with my adult clientele because I just wanted to sit there in the chairs and talk for an hour at a time. And 6 and 7 hours consecutively of doing that made me want to remove my own head and play soccer with it because my body couldn't navigate that. So working with kids allowed me to get on the floor, allowed me to move around, it allowed me to be active with them. And then going into work in schools, aside from the fact that I wore out a lot of pants because I was on the floors of kindergarten classrooms or sitting in kindergarten chairs and moving around all day long, that suited my neurology. So I would look a lot less symptomatic in my ADHD when my environment suited me. So you don't outgrow it. You select environments, you develop skills, but it's a bit of an illusion because parents may see that their kids function better and look more neurotypical in settings that suit them. ADHD is stereotypically thought of as a disorder of boys. And unfortunately, for many years, the statistics have sort of leaned in that direction. For many years, the statistic was as many as three boys were diagnosed for every one girl. And that number has slowly moved closer and closer to 1-to-1. Not quite there yet. It's still slightly better than 2-to-1 boys to girls for diagnostics. But I do think that will continue to change over time. It is not a diagnosis of boys. Boys tend to be more obvious in their symptoms, and we'll talk about that in an upcoming slide. But this is not a true thing. ADHD is a human diagnosis. It is not a gender-based diagnosis. And it becomes pretty challenging. It also comes into play when you think about culture, the idea that we might say things like, boys will be boys. And we excuse the behavior that we see that might be more stereotypically associated with ADHD, immaturity, impulsivity, overactive boy behavior. And we excuse that culturally a lot longer than we might for girls of a similar age. So, always thinking about culture, where you come from. If you're a listener or a participant here tonight who comes from a non-primary American culture, if you were raised in another country, you might feel those differences are even more exaggerated. I know a lot of my family friends are based out of Mexico, for example, and they have very different cultural beliefs about how boys behave. And a lot of my distant relatives don't really talk about ADHD. They just think about it as magnified boy behavior. So culture really does play a part in here. ADHD is not a learning disability, but it affects learning. Okay, it is not a learning disability. ADHD overlaps a lot. People have co-occurring conditions, meaning they can be diagnosed with more than one thing at a time. And someone, for example, with dyslexia, we find that about a third of folks who have dyslexia also have ADHD. So I'm going to say to you one of the phrases that I say on a regular basis to my families. When you read research, the goal of a researcher when they look at a population of people is to try to pick a very clean and simple population. So what does that mean? Tell us in English. In English, that means when I select my participants for an evaluation that I'm going to do to write on research, I'm going to pick a population of people with ADHD who don't have learning disabilities, who don't have depression or anxiety. And I'm going to look at that population to make my decisions and to evaluate my work. And then I'm going to go into a classroom that I've been in, that you've all been in, and I'm going to see a child who might be struggling to get access to some basic needs, who might have a family where a parent is working 12-hour shifts and they don't have access to certain time to sit and do homework with their kids because they're trying to keep the lights on, or where a child who also has anxiety or depression. That's the real world kid that you and I are talking about. So keep in mind that the images that we see in research don't always talk about the real world kids that you and I are coping with and that we're living with and trying to raise and support. And what that means in this situation is that ADHD affects learning. It co-occurs with learning challenges, but it is not in and of itself a learning disability. Parents don't cause ADHD. Teachers don't cause ADHD. Again, if you think that sounds silly, read some research on psychology. For decades, we have blamed parents for anything from schizophrenia to ADHD to learning disabilities. And it's wonderful because when parents take responsibility for helping their kids, I greatly appreciate that. But parents have too much on their plates right now. This is not caused by parents. This is not caused by this. ADHD, while it has a genetic component, you as a parent, if you have ADHD and your child has ADHD, you didn't cause it. It happens to be in your genetics. We pass it along like hair color, eye color, skin color, you name it. So this is not a blaming thing. But very commonly, when a child is struggling with their behavior and who has ADHD and maybe is in the process of being evaluated, parents get asked a lot of questions that come across as pretty disrespectful, asking them about their parenting strategies as opposed to asking more about the kid's functioning. So I always think about that. Parents, one of my phrases that I say is parents are the first and best expert in their child. They're not causing this. Can our behavior as parents, when we're not doing our best and not functioning our best, make things feel worse? Yeah. Can it light a fire under some of our child's most explosive behaviors? Absolutely. Because we parent in the real world, but we're not causing it. We can exacerbate it, we can tweak it, we can make it feel worse, but we didn't cause it. So just keep that in mind. Parents have to be compassionate with themselves. Medication is not a fix for ADHD. In fact, ADHD is not something you can cure. ADHD is part of how your brain works. And if we're in a medical model, Americans all too commonly want to solve things quickly. And if there's a pill to solve it, then I don't have to change my behavior. There's tons of data that says Americans are pretty on board with that, whether it's something like acid reflux or any number of pain conditions that might be caused by lifestyle changes or lifestyle concerns. Americans are really susceptible to medication quick fixes. So just keep in mind, medications are a part of the process for families who choose them. And we'll talk about that at length towards the end of the talk. But this is an important thing to keep in mind. Meds are not a fix here at all. So one of the things I always like to spend an extra couple minutes on is the myth. Oh, so there's a typo on here because I have ADHD. I probably missed that one. The hyperfocus myth. Hyperfocus is an aspect of ADHD. We also see it in other in other disabilities. For example, hyperfocus is commonly seen in autism spectrum. But hyperfocus is a tendency of someone to become really, really deeply engaged in something that's of high interest to them, to the point where maybe you can't even get their attention. When someone says, my child sits for 3 hours consecutively and plays a video game, I think there's no possible way they have ADHD, because it's just a matter of them focusing on school. They just don't choose to. Hyperfocus is a quality of their neurology. It's a quality of my neurology that has to do with the challenges that people with ADHD have in shifting their focus. Okay, it's not just that you can't focus, it's the inability to shift from things that you like to things that are hard for you or things that you don't prefer. It is an area of deficit in shifting attention. So that's something to really consider. It can really delay the process of looking at your child's behavior or their needs if you hold that belief that hyperfocus is something that is really evidence that they don't have an attention concern. It really doesn't mean that. In fact, it might mean just the opposite. So be aware of that if your child really falls into activities and can actually do really cool, complicated things, building a really complex set of Lego, or writing fan fiction, or doing any variety of really intense, detail-oriented activity, could be a sign that some of what they do with ADHD is how their brain can hyperfocus. It's not necessarily that they're not showing ADHD symptoms. For me, the idea around inattention is always a concern, because inattention, it's not you can't pay attention. It's that how you pay attention, how you shift, and how that corresponds, especially for a child, with what the environment demands of you. If you're a student and you're supposed to pay attention to the teacher and you're not interested in their topic, good luck. It's going to be much harder. So it's something we just have to keep in mind, that hyperfocus is something that we really commonly see. And I hate to see us get derailed by that. And it very commonly happens in early assessment process when we're starting the process of response to intervention or screening. And if that's a factor that stops the process, it can be a really big problem in terms of stopping that process from moving forward as it should. Let's talk a bit about the role of these myths in society and what they result in. So when we look at the impact of the myths around ADHD, they really can delay or eliminate somebody's ability to be evaluated or to be served. And one of the key factors here is that when we think about diagnostics, a diagnosis is never a description of your individual child. A diagnosis is the effort of some administrative body, some body of professionals to try to summarize what they see in someone who has a specific symptom cluster, a group of symptoms. And not everybody has those same symptoms. When I talk about diagnoses with my families, one of the things I do is that, there's a trap in the American healthcare system and in the American education system, particularly the public education system. Because in order to get a service in most of those systems, whether you're going to see a psychologist or whether you're trying to get special education service in a public school, in the absence of a diagnosis and some measurable impairment in an important area of functioning, you can't unlock the door to those services. So diagnostics are important if for no other reason that they are the key that unlocks access to supports and services. A diagnosis is not your child. A diagnosis is a tool you use for your child. So if we have stigmatized or mythological beliefs about ADHD, we can restrict our child from getting access to those keys and getting access to things that they really, really need. That not only impacts the individual, it impacts society. It impacts your entire classroom. And unfortunately, it affects the trajectory of that child, their ability to go from being challenged and struggling to someone who's learning strategies to accommodate their differences and to learn to thrive. So the myths are a huge factor in navigating this. And sometimes I use the word caricature for a reason here. If you think about, the caricature of ADHD, what is a caricature? You go to Atlantic City, you go to some sort of beach community, and there's almost always an artist sitting on that boardwalk somewhere who's going to make a silly picture of you that makes you look like a cartoon, and your head's 4 times the size of your body, and your nose is 30 times the size of what it is. That's what caricature is. ADHD diagnoses are a bit of a caricature too. They often focus on the exaggerated aspects as opposed to the real details of who that child is. The only people who know those children are the people closest to them, their parents, their teachers who are paying attention, and those who are really living with them, not trying to define them based upon some criteria. One of the problems with these myths is that it also blames the child with differences for their behavior, as opposed to acknowledging their wiring differences and what that means for their functioning. This is a huge factor. If you think about how you are trying to cope with those differences, what you hear is blaming language, unrealistic expectations, and perpetual experiences of failure that start to affect how that child is going to function. And that can become part of their self-image. It can become part of how they feel about and respond to school. If learning is hard and they're never supported, it can become a source of anxiety and phobia. You connect the experience of school with failure, surprise, unpleasant outcomes. And it's not surprising to me why so many kids lose their love for learning if they're not being seen with a fair view and being seen honestly, as we would see when we strip away these mythological beliefs. And obviously, one of the things that happens is that myths about ADHD aren't just flat out lies. It's that if they were just flat out complete and utter inaccuracies, we would be able to sweep them away a little bit more easily. The problem with the myths about ADHD is their magnification and distortion of some things we see in some people. So that allows us to say, well, I see this, so it must be true, as opposed to looking deeper at the information. And that's one of the things that's so important to me as a psychologist, is that if I can share perspective that's real world, that speaks to my lived experience, and that resonates with your lived experience, we can sweep away these myths and barriers and get our kids the support that they need. And that's such an important part of what we're doing in having events like we have here today. Okay. One of the things I want to also talk about here, not only is it a barrier to their understanding of their diagnosis, but one of the most important things that I talk to kids about throughout their educational lives is the concept of self-advocacy. How do I get them to express their own needs with rationale so they can get the things they need to be more successful? When kids are told that they're incorrect, that they're not working hard enough, that they're receiving criticism that is unfounded, that is inaccurate, they're not going to self-advocate. They're not going to do the things they need to do to get the help. What they're probably going to do is shut down, or they're going to show you the behavior that's going to make everybody miserable. They're going to act out, they're going to steal control, or they're going to steal power by way of grabbing your attention. The one thing I'll often say to families about behavior is that the most reinforcing thing you can give a child is your attention. And sometimes misbehavior, when it breaks up the frame of what you're trying to do, that's the only thing you're going to be able to pay attention to, because it's disruptive. And it's so easy to reinforce that because of what it does to us in that environment, for teachers particularly. Okay. So let me take a breath here and give just a couple of moments. Kathy, I'm not monitoring the chat directly. Are there any concrete questions on some of the slides, things that might be confusing to people that would be helpful to address in the moment?
I think there's one you might be able to answer fairly quickly, and that is Jen wrote in and asked, do other countries have high levels of ADHD as well?
That's a great question. The cross-cultural side of this, not all countries are using sort of the Western medical approach that we are, and many countries that have that are focused on mental health, like we are here in America, they do see some similar proportion of ADHD in their kids. But there are many cultures, when we have very, how do I say it, very paternalistic cultures who would underemphasize ADHD. So for example, in places like China, in a lot of the very paternalistic male first cultures, we see less of it. The other thing that I like to express is that the American diagnostic system that we use, this DSM-5, is different than what they use in Europe and in other places. For many years, they were using the same system as us, but with the recent changes, and I say recent, within the last 10 to 12 years, have actually been rejected by a lot of European communities, and they're using the international codification systems. So we see it in a lot of other places. ADHD is definitely seen across cultures as a general rule. How different cultures respond to it varies pretty wildly. But yes, it exists in other cultures. The same way that we see we see autism in other cultures, we see schizophrenia across cultures, but a lot of the mood disorders, things like anxiety and depression, lots of other cultures approach them differently than we do. I think that's a great question though. So, all right. I will do that periodically if there's stuff that comes up that is really tied into the existing slides. I'll check in on that periodically. Okay. So let me ask a detailed question that Kathy, you can. I'll just have a couple of responses. I don't want to fill the chat with this, but so far, how is my pace okay for you guys in terms of, am I talking too quickly? Is it working for you in terms of my pacing? All right, fair enough. I actually was able to open that up here, so I won't put Kathy back on the spot. Thanks, guys, for letting me know. All right, I'll jump back in here. One of the pitfalls of this for me is that because of my ADHD, this is an area of hyper focus for me. So when I get involved in these conversations, I can nerd out pretty hard on it because it's really interesting to me and it's extremely important to me. Okay, and all right. So expanding on some of the questions here on myths and the impact of society, one of the things that not everybody is aware of is that the longer you have a neurological or learning and thinking difference like ADHD, the longer you go without getting supports for it, the greater probability you have of having mental health concerns like anxiety and depression. This is something that I knew intuitively for many years because what I see is so many kids with ADHD who are definitely the ones who are struggling with behavior. Here's so much corrective, no, stop, don't, or corrections on you need to work harder, you're not pulling your weight. If you would only just attend, if you would only just put out the effort. And when you have all of these negative messages and negative feedback from your social world, it's impossible not to start to internalize some of that. So if you are a parent debating, do I really want to go down this road with my child? There is a possible outcome for you that your child could be getting worse and having more emotional concerns because we're not addressing this. By addressing what your child's differences are, doesn't mean you have to do medication. It doesn't mean you have to do therapy. What it means is the more you learn about your child, the better chance you have to support and protect them from things that can make their lives a lot harder. And there's an awful lot of ways to get there, which we will get to in the later slides. If we continue to let these myths live and we don't correct people out in our real world, we're going to allow society to continue to portray lots of inaccurate images. We see this across the media and social media and the public awareness. The nice thing is that public awareness is really growing with ADHD these days. There's been a massive movement within the adult population using TikTok to talk about adult ADHD. The challenge there is that while I think it's great that people are creating community and sharing information, the hope is that people will go to credible information to really learn more about the diagnosis, as opposed to just focusing on the most dramatic aspects. So my example would be this. Having adult ADHD doesn't mean you're just some sort of forgetful, klutzy buffoon. And unfortunately, a lot of the portrayal of that is what people see on sites like TikTok. Ask my wife and daughter, and they'll say, yes, he is a klutzy buffoon. We love to see him fall out of his chair when he's doing presentations because it's possible. But that isn't a defining characteristic of ADHD. It's just an exaggeration of some of the things that happen that can be sort of funny. And maybe that breaks down some of the barriers for folks who have ADHD. But again, making sure that when you're accessing information, get solid information through sites that you trust. We're going to be sharing some links with you at the end of the talk. And I hope that the information I share can be things that you reference to others, just to keep things feeling, feeling fair and notable and evidence-based. One of the things that we see very commonly is the idea that best practice treatment options really need to be discussed, and people need to know that information so they can overcome some of the myths about medication, behavior therapy, and the like. And that'll give people more access to considering things that can help their kids. Absolutely, the myths discriminate against women and girls. Women and girls are significantly underdiagnosed. One of the things I do in my private practice is I do a lot of private ADHD assessments. And I would say to you, with my adult population, 2/3 of my evaluation clients are female. And a lot of the stories are the same. I had differences when I was young, and they diagnosed me with anxiety or depression. I never felt like I was getting the support I needed. And now they realize as they're hearing more information about ADHD, that maybe what they were experiencing was more about their neurology than just their mood, which got worse over time as they didn't get supported. Okay, we talked about self-advocacy. And finally, the myths of ADHD prevent people from thriving. They stand in the way of them getting the things that they need. All right. So let's talk a little bit about the differences in gender and ADHD. And I think these things are here to help us break down some barriers. So, I want to consider the idea that these differences are far from universal, okay? There's a culture to account for in this profile in that, girls within American culture are supposed to present in a certain way. And maybe this is a little bit of an old school culture, but we don't really expect girls to be, we don't expect girls to be as outgoing, as physical, as hyperactive, or as physically engaged in their environments as we do with boys. And this has been something that our culture has supported and shown for as long as I've been alive. So this leads to girls being diagnosed with mood concerns at a far higher rate than boys. One of the things that we have to keep in mind in these gender differences when we think about ADHD is that there are differences at birth that come into play. If we look at developmental psychology, and I'll give you just like a 3-minute developmental psychology lesson, the default human the default human condition is female. So when there's an embryo in utero in that mother's belly, okay, I'm going to be very, very vague, in the mother's uterus, the default position for that baby is it will develop into a girl, unless at some key points, hopefully at the right key point, they're exposed to androgens or testosterone. And then at that point, they develop into being a male human being. What we see is, as a result of this period of time in development, and the research supports this well, is that little girls tend to be born further developed than boys are. Girls develop walking and talking skills a little bit earlier, are a little bit more psychologically mature at an earlier age than boys. So when we think about those differences, those impulsive, overactive, high energy behaviors that are more stereotypical in boys with ADHD, those are even more magnified at times due to development. So one of the most common things you'll hear from your pediatricians, if you were bringing in a 3 or 4-year-old boy or girl for assessment for ADHD, is they're very likely going to push back and say, let's let development happen here a bit and see if they mature naturally on their own. And that statistically is a pretty realistic and reasonable statement for them to make. I trust parents first, obviously, because parents know their kids. But the idea around this, there is some genetic differences in those early developmental moments. Boys tend to show more externalizing symptoms, meaning their behavior affects the people around them and their environments. They misbehave, they're energized, they might be louder and engaged in certain behaviors that are more typical in that way than girls are. Girls are actually reinforced for being quieter and politer and more in their space than boys. But because of their maturation, they're more able to do this at younger ages at times than boys. Impulsivity, acting out, grabbing, being physical, this is something we see more in boys at young ages than girls. Impulsivity can also be cognitive in terms of, let's say you're making a decision. A little girl can be just as impulsive as a little boy, but maybe she's impulsive when she's taking a test in school, or when she's making a decision about what she wants to eat, or a decision about how she's going to choose a friend to play with at lunch. So keep in mind, impulsivity can be subtle, or it can be obvious. And then we see self-control differences there. When we look at these differences in girls and boys, I look at these stereotypes, but they're supported within research. And I see very clearly there's evidence of why I was diagnosed later in life, because I didn't show the stereotypical male patterns of ADHD. I showed a much more stereotypical female pattern. I was all up in my own head and distracted. I did not act out in the same way. My brain was overactive, but I had that impulsivity that affected some of my other decision making. So just keep in mind that these differences are really actually supported in some of the research. What does research talk about? This kind of research talks about big numbers of big groups of kids. So this may vary. This may not apply to your child. But if you put 1,000 children in a group, we would see that these tendencies would show themselves in terms of large numbers. So just keep that in mind. Statistics are great for describing an entire group, and how the groups vary may not be great in describing an individual or your child. So just keep that in mind. I think that for me, being reasonably bright and verbal, but disorganized, made it harder for me to be diagnosed. And it certainly meant that I was going to get a lot of criticism for the behavior that was academic. Focus more, be more organized, try harder, as opposed to, I wonder if his brain is wired differently. That was not going to happen in my New York City schools back in 1972, 1973. Okay. All right, take a breath here. All right, let's talk about some of our treatment options and treatment information here. So when we think about our treatment options and thoughts, current research really speaks to the idea that the best outcomes in research for ADHD are a combination of medication and therapy. Okay, the combination. I'll give you the caveat that I gave all my students at the University of Maine. Whenever I taught abnormal psychology, there was a rule, there was a good cheat rule when you were taking tests on psychological interventions. You can be pretty confident that if you were asked, is medication or therapy better for treating a condition, or there was an option that said the combination of medication and therapy, that was almost always going to be your correct answer. And then in addition to that, there was always a little bit of data that would say, and in some cases, behavior therapy or cognitive therapy by themselves can be equal to the combination. So what does this say to us? In essence, what it says to us is that using a greater array and variety of interventions is often the best way to support your child. Does that mean they need to be medicated? Absolutely not. What we're talking about in these intervention systems is just making sure that we have familiarity with what's being done in our communities. If your doctor or your counselor mentions these to you, or they're mentioned in schools, understanding things like behavioral parent training. This is a pretty concrete form of training. This training is teaching parents a variety of parenting strategies, ways to help manage day-to-day moments with your child, and how to be really structured in how you approach your child's learning and emotional needs. And there's lots of good research support for it. Cognitive behavioral therapy, or CBT, is one of the most research supported methods. And it really, again, it is a continuation of what we talk about with behavior therapy. Behavior therapy for a lot of us is a lot of talking about things like rewards and consequences, or maybe a more accurate word there is contingencies, meaning if you do a certain behavior, there are going to be certain outcomes that we need to pay attention to. And the therapies that use cognitive behavioral therapy actually start to talk more about thoughts and feelings as they relate to a child and adult's behavior. So again, these therapies are extremely well supported in the research and are great options for helping kids with ADHD. If we think about some of the options that fall outside of the realm of the traditional therapy methods, some of the things that I like to share with folks is that when we think about interventions, for many of us, we like the idea that intervention isn't intrusive into our family lives. So going to therapy for some families is something that's incredibly uncomfortable in terms of their culture. And looking at what can I do at home? How can I be effective in helping my child be successful? So there are a lot of specific things that we can read about. For example, biofeedback and neurofeedback. Got a lot of information, a lot of attention for a couple of years. And the idea around biofeedback and neurofeedback, specifically neurofeedback, is measuring brainwave activities through little monitors. They're not invasive, they just sit on the scalp. And to measure while doing activities, if we can train children to calm their neurology down and lower the ADHD responses, the impulsivity, the inattention, and some of their ability to focus and engage. And for some individual children, there was some positive benefit. Unfortunately, the most recent research has shown, and this is pretty recent within the last 18 months, that we're not necessarily seeing the impact that we hope to. And the thing with neurofeedback, while it isn't medical intervention like medication, and it isn't sitting and having talking therapy, it was always hopeful that we were always hopeful that there were methods that we can use to help train children to be aware of their bodies and to take care of them in a way that helped calm them down. There's still hope that there are developing therapies within that model, but really there was not any known impact. So what we call this is all psychobabble. I'll define it here in a second. WMI is working memory. EF is executive function or impulse control. Working memory is the brain's ability to take in tidbits of information, to hold them for a moment, and either manipulate them, use them for an activity, or repeat them back. Those are the kind of things that we do that require us to pay attention in the moment, to look at someone, to hear what they're saying and try to capture that information. And that's an area that can be a deficit in ADHD. Executive function is a really good psychobabble term. If you have a child with ADHD and you don't know the term, I would encourage you to spend a few minutes to learn about it. Executive function is a neuropsychology term that talks about how do we take in information and sort that information by what's useful and meaningful and what's not. How do we organize the information that we learn? And how do we decide how to plan steps of an activity, including knowing when to start an activity and when to stop an activity? And that's an area that is really commonly affected with folks with ADHD. Leads to disorganization, problems following multi-step directions and activities, and it can make them really avoidant of things that require a lot of cognitive focus and energy. So keeping that in mind is really important if we think about things you may want to put some attention to for your children. A nice alternative here is talking about exercise. There's been some really nice research data that shows exercise can affect kids' ability to attend and concentrate, can lower their energy levels and hyperactivity to a certain degree. And the reason for this is that for many kids with ADHD, their neurological systems are actually understimulated. They're not getting enough stimulation. So what they do is they seek stimulation in their environments. Or when you bring stimulation in, what I mean by this, if you're sitting in a quiet room, someone with ADHD is much more likely to pay attention to or be distracted by a sound in that environment because their body does not have strong enough filters to say that's not important. Their body is craving and seeking and searching for it. When that body gets exercise, they fire off dopamine and norepinephrine, which regulate the attention system and sort of bring that body system a little bit higher into a more neurotypical area. So what they found is with regular intense physical activity, really strong running around play, 30 minutes at a time, 3 to 4 times a week, the kids were showing some improvements in their ability to manage some of their ADHD symptoms. This is great because what it means is we sometimes really just need to give our kids a chance to move around and give them that opportunity to spend that energy. Finally, some information here about white noise and brown noise. I don't know how many of you folks are familiar with this, but there was an accidental finding. This Scandinavian researcher was trying to evaluate what kind of things distract kids with ADHD. And what they did was they found by accident that when kids were given white noise or brown noise sounds while they were trying to concentrate and focus, it actually led to improvements in their attention and focus. He was trying to use it as something to distract them with, and it turned out quite the opposite. And it's created some very, very interesting use. So using white noise machines to help people concentrate while doing homework or to block out sounds while people are trying to sleep. Those sound screen apps and things that people have. There's a variety of reasons why they think this happens, and it's still very, very developing research. But one of the theories is that if you have this white noise going on in the environment, it raises the threshold, meaning you're taking information into your brain that makes it harder for things that aren't relevant, like a random sound, from interrupting and knocking their attention out. So in that situation, it's incredibly cool to think whether that is what we call auditory masking, meaning blocking sound by putting another sound over it, or if it's actually part of our brain firing the dopamine because it's getting enough stimulation that it's able to equalize the attention. So it's a pretty interesting, low impact and very unintrusive form of intervention that if you're working with your child, trying to get them to concentrate, trying to help them study during an after school time, it's worth looking into. ADHD and medication. So let me give you my caveat here because I think it's extremely important. I am a psychologist, and as a psychologist, I am not a medical doctor. I cannot prescribe medication. I am in no way affiliated with any pharmaceutical industry, company, or persons who benefit financially from what the medication companies provide the pharmaceutical folks. So when we ask these questions about medication and treatment for ADHD, I approach it from what I call a scientific pragmatist perspective. Scientific meaning I'm always going to look at the data because there's lots of data, but I'm going to be a pragmatist, which means if your family culture is not interested in medication, you're concerned or you're worried about medication for your child, it is not my purpose to try to convince you. It is more my goal to give you a balanced variety of information so that you have a sense of what you're going to consider for your child and you have the best data available to you. Okay. So do you have to medicate your child? Well, the answer to that question is unequivocally no. You don't have to medicate your child. The medication information that's out there shows that there are multiple classes of medication for ADHD. There are the stimulant class, which is the most commonly used, the one we know the most about, the Ritalin, Adderall, Concerta family of medications. And then there are the non-stimulant medications, which people use when they're concerned about the impact of stimulant meds. And the non-stimulant medications are generally based on medications that run anywhere from modified blood pressure medications to a very low-level antidepressant. The goal of these medications is to help with managing those core symptoms. The primary data shows that stimulant medications are effective in 70 to 80% of kids, but not all of these medications work well or the same for all kids. And they may not work or have prolonged benefit depending upon who your child is. So finding that right medication is something that is really an experimentation process. Saying that about your old child's neurology can be terrifying to some folks, and I completely appreciate that idea. But when you're trying to find something to help your child, using professional advice, working with a qualified physician, and really making sure that that doctor listens to your voice, is able and willing to take information you provide with them, and is able to be in contact with you if you have questions, is incredibly important. Most of the people that I've worked with over the years have kids or themselves, they want to discontinue their meds, or they refuse, or at some point, particularly as my clients get older, they decide they want to take routes other than ADHD medications. We have to be aware of that as a possibility because it could affect how we think about their treatment needs and what their treatment options are. So when I think about medications as a tool, I'll use a terminology that may be familiar to you at schools. The model that I think about with any intervention is I like to use the least restrictive intervention model. So when you think about that in your school settings, it's the idea of if you have a child who has a mild attentional concern, you're not going to place them in a self-contained special education classroom for their entire day. That's way too intrusive. The same goes for medications for some folks. If I can use a tool that is non-invasive to my child's neurology and gives me the opportunity to do something active with them, for some families, that's the priority. So keep in mind that that's something to be considered in your process. Medications can be an effective tool for ADHD. The preference that I always express to my families is that they're the best tool when used in combination with therapy and other interventions. Why? Because sometimes you just have to consider the fact that we want to build the best number of skills for your child in that process. Some of the pitfalls of the medication aspect here is that you have to consider when it's most important or when it's most meaningful. There are children that I've worked with over the years who have been so severely affected by their impulsivity, their hyperactivity, and their inattention that they couldn't even sit for a therapy session until they engaged in medication management. Was it a common thing? No, but 10, 15% of my kids had that level of impairment from their ADHD. So it is a consideration. If your child is literally in emotional pain, cannot function, is in extreme emotional distress on a regular basis, and your efforts at using less intrusive methods isn't working to start, you may need to consider medication for that child, then bring those services back in, which may give you the best chance for success. Medication only models are a little bit of a pet peeve of mine. And I'll say that it's a bias of mine. Why? I'm a believer that we as a culture, I said this a little earlier, have very little tolerance for distress. I've even coined it a limited tolerance for distress disorder. It's an American disorder. If something makes us distressed, make it go away quickly. And a medication-only treatment is a fully passive approach. It doesn't focus on giving your children any concrete skill building or opportunities to learn something about how to improve their own functioning. So I think about the fact that 70% of American kids are getting medication-only interventions, and I worry about that. I think that can be problematic, and that's something to consider. And again, that's my perspective. So when parents ask, why would they ask for medications less? For a lot of reasons. Least restrictive environment model. Parents don't want to intervene using methods that bring in chemical substrates to their developing brain of their child. Completely understand that. The idea that they want to look at other service options. Medications by themselves don't teach your child anything. They might provide an opportunity your child didn't have before, meaning if your child is available for learning about information, they're able to attend and concentrate. That opportunity would not have existed without the medication. But concretely teaching them skills to organize themselves, to build executive function skills, to improve problem solving and teach concrete social skills are things that medications obviously don't do. There are pitfalls with medication use. If you can't monitor your child's taking their medication, if you are not able to pay attention to their side effects and track them, and to track the positive impact of those medications consistently, then medication might not be a good option for you and your family. When we think about what ADHD is, it is a diagnosis that takes into account the neurology, what's happening in that brain, but it's also reflected in the behavior of the individual. And that behavior is where we have to put our attention in terms of intervention. That functional skills development is where we can have additional impact. We can magnify the impact of the medication if it's done appropriately. We can at the very least improve functioning by teaching those skills in the isolation from medication. So the options are pretty varied. Medication use over an entire person's lifespan, I've not seen a lot of it. I've been working, so I'll give you a little bit of background. When I started working with my clients, I work with very young clients at the beginning of my career. Some of my first clients who I did therapy with back in my beginning of my career are now in their late 20s, early 30s, and have kids of their own. And I would say of all those people that I worked with ADHD, very few of them used medications continuously. One, for some of them, it wasn't practical. They couldn't afford some of the medications. Two, they chose not to. And they would often say to me, I need to learn more skills. Medication isn't like taking a Flintstones vitamin. You can just give it to somebody and everything's cool. It requires monitoring and tracking and compliance with the prescription that you have. So thinking about medication as something that could stop working, or something that someone might choose not to use in the future. And that is a good enough rationale for making sure that we think about other treatment options and giving those options to families. So let's just briefly look at a couple of the realities here of ADHD. So I'm putting this slide up for you guys, not because we're going to spend much time on it. It will be provided to you later. This is something particularly for educators or for parents who are working with their kids on school activities. That was something I put together with a few of my teachers that gives you a little bit of a breakdown of what might you see with your child when you present a task for them to them and see how their behavior could come into play. Kids with ADHD are going to show you a lot of different reactions to things you ask them to do. And this is just a breakdown of maybe ways to think about and approach some of their learning and emotional needs, particularly when you're doing activities like school activities or teaching new skills. I don't want to spend too much time, but it was something I really like to share with folks. 2 slides here on accommodations for school. Accommodations are really important for kids with ADHD. And I say accommodations as opposed to modifications. Accommodations are those things that we do that maintain the flavor and maintain the content that they're supposed to be learning, as opposed to modifying and reducing dramatically the demands on our kids. The goal is to keep our kids engaged in the same educational content and rigor as anyone else. So to accommodate for them takes into account things like be open to the idea of allowing your children body movement and changing posture. Not everybody needs to be seated in their chair in the same way at the same time. If you look at many of these accommodations, ask yourself, are these accommodations things that actually might help all my kids, not just my kids with ADHD? That really speaks to the idea of, we think about least restrictive environment, we think about change in culture, we think about all the things that we do in terms of just shaping our learning environments. Executive function supports, breaking down multi-step tasks in advance for all kids and giving them the opportunity to see how we break down tasks. Don't assume that all brains can do it. Give them that opportunity to walk their way through those challenges. Giving opportunities to create quiet space, use noise blocking headphones, or block those sensory distractors that could be affecting your kids in general. Extra time or shorter testing opportunities for testing and task completion. That's a little bit more of a modification. The extra time is an accommodation, but if you're going to shorten the sessions or reduce, then you're going to be modifying. But the key here is not all kids can sit for the same amount of time to do the activities to show you what they know. So if you can break it into multiple sessions, if you can give them extra time, these are always good opportunities for them. Preferential seating is one of my bugaboos, and let me give you the reason why. Preferential seating when I was a young kid in the 70s meant they put me in the very front of that classroom, and it was the worst place for my ADHD. Do you know why that is? Because all of the neurological stimulation was behind me. The teacher was often the least interesting party in that classroom for me. So the voices, I was swiveling, the voices behind me, the sounds behind me. So finding out where that child is best suited in that classroom is something that needs experimentation. Keep in mind that that location for your children might be on an aisle towards the back. Why on an aisle? Because you want to be able to get to them and give them a nonverbal cue to help them get back on track without embarrassing them. So giving them that opportunity to be surrounded by enough stimulation to feel under control, but not to be too overwhelmed by that. Finally, we have to think about, and that's when I refer to low stimulation or nonverbal cues. If you have a child who is struggling with attention, coming in and speaking loudly or trying to make a noise to bring them back to you is embarrassing, is something that will over trigger their stimulation or their sensory system. Sliding a card under them that says focus, tapping on something that's already on their desk that cues them back to re-engagement. These kind of low stimulation nonverbal cues are huge. It also prevents them from being embarrassed. Fixed locations for materials and processes for turning in work. Leave out your process, make it concrete, and use it the same way every time. So that if something you need to remind your child about a process, it's written down already and you can refer to it. There is nothing more frustrating as a parent or as a teacher than having to say the same thing over and over 10 times. If you've got to write it, if you got to say it 3 times, write it down, laminate it, make copies, and put it there so you can point to it and take a deep breath. Teach your organizational systems to your kids so that they can use their own strategies numerous times a day, including how to put things in their backpacks. Where do they put their materials between work sessions? Teaching those skills are life skills. Those skills, when learned at a very young age and becoming habits for them, can make a massive difference in them as educated young people in their futures. And finally, provide opportunities for controlled and safe movement within your environments if needed. Those bodies need to move. Right now, I am absolutely I'm like a coil right now, ready to just spring out of my seat because I can't usually sit for this long. All right, folks, that's it for my slides right here. So maybe we can open up to some of the questions you have. I'm going to stop my screen share here. All right. You're muted there, Kathy.
I thought I clicked it. Thank you. So we have about 13 questions that came in. A couple of them I feel like were asked and then you got to them.
Okay.
Two of them surround exercise, and so I'm going to kind of package those together. Would you recommend exercise for a child that has ADHD but is not hyperactive? And part two of that is, does the time of day that the child exercises matter? Like, should we do this in the morning before we go to school, or?
Super question. So yeah. So absolutely. So great questions. Using exercise for kids with ADHD, I would use irrelevant of whether they're hyperactive or not. Because remember, hyperactivity can be cognitive. Their brains can be overactive. And by providing that the moments of the dopamine surge that they're going to have from exercise and the norepinephrine surge can improve attention and focus for any of those kids. So without a doubt, I would say that it's good across the board for those kids. Even if you can't get super intense exercise, if your child is just not sporty, so to speak, right? But you can do things like tag and chase, and doing things like scavenger hunts with a timer are great ways to get your kids to engage in brief bursts of exercise related activities that are still fun and don't have to be ball sports and games. Time of day, I'm biased in this regard. The research did not say what time of day. My bias would be doing something before you start the school day at major transitions. We see a lot of this in schools, a lot of classrooms doing like a go noodle or getting up and doing some movement activities. My experience of those is a little mixed. I find it winds up a lot of some kids and helps others. But in the grand scheme of things, focused, consistent activity, then when they get home. Between major transitions, if they get home from school and they're going to do work at home, I would absolutely do an exercise activity before seated work activity. And remember, as I said before, I'm not a believer that you always have to be seated. I think you can be on your belly. I think you can be standing. If you have the opportunity to do dictation, give your kids a chance to move their bodies. It's very difficult for them to stay seated all the time. And I think that our culture does that way too much. So I would emphasize letting them move. But those are two great sort of, those are great shades of that content. That's great questions, guys. So what else have we got?
Yeah. Thank you for that. How do you recommend educating someone who believes and voices some of the myths you mentioned about a child? And with that in mind, what could an educator do to find out, okay, so what are the strategies and things that I could be doing? We get the recommendations from psychologists that say, preferential seating, as you mentioned, and, may want to do a trial of medication and that sort of thing. But what do you do when it truly at times it can come across as intentionally disrespectful, and yet the child is struggling and is having trouble? So what is a teacher to do, and how do we educate people in what can I really do practically that's going to work for these kids?
Yeah, it's this is like a bad Facebook status. It's complicated, right? The idea is that sometimes when you have a parent who might be somewhat defended or stigmatized in their view of what you're seeing their child struggles to be, your best option is to be problem focused. When your child is doing this kind of activity, here are some suggestions that we see is really helpful for them and other kids who are struggling in those same ways. So a lot of this is about trying to be, I said this before, I'm a pragmatist. I don't have to worry so much about the diagnosis in the early phases of working with a family. If the family's not on board and they're not really aligned with the idea of maybe a child having ADHD, it's good to at least align on the shared observations and trying to share your perspective. And if you share, I see, this is my favorite way to phrase this is, I notice when your child is doing X, Y, or Z. A noticing term is about observing the child without judging the child. And that is really powerful
Yeah.
because most communications that we get from teachers to home are when it's a problem. If you know you have a child who's expressing problematic behavior with regularity and you're finding yourself feeling trapped in those parent interactions, there's a strategy that I use this in one of my schools where we had a lot of families who were feeling like we were being overly negative. So we created a schedule that when I had a child who was really struggling controlling themselves, the teacher and I scheduled for every day that that child did something that we liked, we called that family because we wanted to turn that caller ID into a different kind of trigger. If you see that caller ID, it's the school, and it's just like you start to teach the parent that you're a negative stimulus. So bringing in that positive with regularity, sharing what you like about their child, and not saying, Johnny's a really nice boy. Don't you dare say but. Okay,
Yeah.
don't you dare. And I like that he did this, this, and this. Hang up that phone and leave on a high note. Okay, take that as an opportunity to share a positive and stop. You have plenty of days to navigate some of those other moments, but share with those families your perspective, your observations. Share that information in a way that at least talks about a problem focus and how you're going to solve it together. That's going to be your best avenue. Once you start to build some credibility with those families, you may have more ability to share resources with them to allow them to absorb them over time. You
Yeah.
can't, we're not responsible to be the full agent of change on all this. It's too deep a responsibility. You've got enough other things that you're responsible for when you're teaching these kids, you
No, I
know?
know, I know. And certainly more than enough students in each of the classrooms. Somebody just posted a question and it's actually helping me to connect to another one. So give me just a second and let me think about this. Somebody put in the chat, could you talk a little bit about kids who have ADHD? And Andy, you kind of described yourself this way. Talk about kids with ADHD who have managed to sort of mask it and succeed, but what are the effects of that extra energy that it's taking to have that success, and how can we best support them so they don't burn out? And Lopa just put in the chat, they're masking and they're people pleasers, so it doesn't present in the same way, but the school doesn't think that they need any assistance or support or accommodations because they're doing fine.
Yeah. And so then, so the thing I would ask you in that situation, you've described a great scenario. So then I would have to ask, where are we learning that this child is struggling? Where is that information coming from? So if we're not seeing it at school, then the question, I guess I'm reinterpreting the question to be, how do we help parents then decode that for the school? Okay. So when it comes to decoding that for the school, I think for parents, it's really important to try to create a little bit of a narrative. You know, um, Parents writing a little note. I want to share with you a few things that I noticed about my child that may not be apparent to you in school, and then share the shared knowledge, which is, my kid really wants to please and is really eager to be compliant and to show that I'm going to use the she here because I think that was the content. She really wants to be seen and liked by you. What I'm noticing at home is that she's spending a lot of energy masking or hiding these things from you when she doesn't know what to do. So here are some of the things that I've been doing. And I was wondering if there's some way that we can talk about how you can do some of these things, even though she's not asking you for it. Because I really do think she might ask you if she knows that it's something that she could benefit from. Kids are less likely to mask if we offer them something just out of the blue that seems, this is really helpful to a lot of kids. And we offer the strategy we learned about from the parent without having to say that it's a problem. They can maintain our approval, they can maintain our positive attention, but we can give them a hack, a
Yeah.
tweak to this. The best way to break that down too, teach it to a couple of kids. Okay. Teach it to that child and their best friend. Doesn't matter if the other child doesn't have a deficit in that area, because a good organizational or a tweak skill that's good for the 1 in 5 kids is usually good for the 4 out of 5 kids as well.
Yeah,
So I think
absolutely.
that becomes really powerful.
Yeah, agreed. I know when I've presented at schools and oftentimes I'm presented with the faculty who's really afraid to put any of that into place without
Mhm.
a diagnosis or a report or some paperwork. And you think about the number of accommodations and strategies we could put in place that, again, as you said, would serve all students.
Yeah.
As opposed to just that one student. How early in development does ADHD start sort of manifesting itself, start affecting day-to-day tasks?
It really varies. I mean, I hate to, I really dislike that of having to say it depends, but it really does vary, because there are other factors. Um, Impairment is the primary thing that you're asking me about. So when do you most likely see signs of that impairment? Okay, and it depends. So, for example, if you have a reasonably bright and verbal child, you may not see some of those challenges until grades 3, 4, 5, when the organizational and interpretive aspects of the work start to get past their threshold for doing something automatically. Okay, for really bright kids, middle school is the cauldron of hell, because they're being asked to do so many more executive function
Mhm.
skills independently and
Yep.
between classrooms of other places, different teachers. So it really is going to depend. What I would say is that, the earlier that the impairment is seen, whether it be, the behavior, the hyperactivity, the intrusive stuff, the earlier the behavior is seen, the more important it's going to be that you attend to that behavior. So I think that's really the answer that I'm going to share with you. Um, I try really hard not to diagnose too young, because
Yeah.
there's a lot of explanations for energetic young kids who are inquisitive and maybe even a little, I'm going to use the word off the cuff, it might be a little bit challenging, because the why of the world is more important to them at a younger age than some other kids.
Yeah.
There's nothing quite like kindergartners and first graders who just sort of do what they do. And then
Yeah.
you get the rogue kid every once in a while. Why do we have to do this? I don't really understand. And you can look at them like, hmm, that was, where did that come from? Because you're not, one of these things is not like the other,
Yeah.
and that I ask teachers to embrace that privately, to say, what does that mean? Like,
Yeah.
that kid's giving you something about their neurology.
Yeah.
But again, I just say it's important to be alert and to be open. And if we teach organizational skills early, we teach those executive function and task breakdowns early, and we
Mhm.
teach good rituals for learning, kids will start to show us where the deficits are in spite of those trainings. And it's going to be a little more functional. It's also a heck of a lot easier to work with executive functioning organizational skill if it's part of your classroom culture. And
Yeah.
that's something in a public school, it's not part of the teacher's guide, it's not part of the curriculum. And it's unfortunately something they don't feel they have time to do, because they have so many other demands for testing, curriculum, being supervised, being rated, being
Mhm.
evaluated. And what I say is that we're missing the boat.
Yeah.
These are life skills. And if you don't teach them as part of the curriculum, you're not going to give all kids the same chance to thrive.
Yeah, when I learned about executive function skills and started just integrating that, if I'm assigning a book report, part of that is going to be I'm going to share with students how are we going to break that down and have them come up with a
Yeah.
plan. If I do that and I'm integrating it like that, it's actually saving me time as the teacher on the back
Oh,
end.
yeah. Yeah,
For
absolutely.
a lot of knowing what you know now about your own diagnosis, do you wish you had been put on medication as a child?
Wow, that's a loaded question. That's a tough one. That's a really tough question.
I know I like
Um,
it.
yeah, it hindsight is what it is. I only tried medication as an adult. And the medications available when I was a kid were not really as well refined as they are today. So, for example, as an adult, they gave me a trial of Ritalin, and I felt very poorly on it. So perhaps at that time, it may have not been as big of an impact. The thing I wish they gave me most were the skills training.
Mhm.
Help me organize and break things down. To me, that would have been the most helpful thing they could have done. But the fact that I wasn't identified, I'll speak very, very openly about this, led to me having periods of anxiety in adolescence. that was very difficult for me to navigate. And because I just couldn't, I was struggling to predict as a teen why everything was so hard. I knew I was a pretty smart kid, but I just couldn't understand why this stuff was blindsiding me so often. So I really think I needed the compassion, I needed the instruction, and I needed the awareness. I don't know if the meds would have done what they would have done for me then. I can't predict that. But
Yeah,
those other things, those are the things I knew today. I know today that would really help me. And
yeah.
I wasn't severe. I don't have severe ADHD in terms of like that the stuff that really would have impaired me. I did okay. I
Mhm.
never fell off the rails academically, but I
Sure.
never achieved until I got to those higher levels of academics.
Yeah, absolutely. There's a lot of questions about executive functioning that are either popping in now or were asked earlier. And I want to talk a little bit, you keep talking about skills training, and I think that's kind of what you're getting
Mhm.
to there.
Yeah.
Can you, first, do you think it's safe to say that children aren't always going to be real open to getting that instruction from their parents?
Yeah. Well, no doubt. No, without a doubt.
Okay.
And the reason this is too is that kids know when we're full of it. Okay. If you don't have organizational systems in your home and you're a bit chaotic or you don't really have those systems, and you start trying to bring this into your environment, the kids are like, you're full of it. They're not going to buy into that initially. And they're tired of it by that time of the day.
Yeah.
But in a classroom, you have bell schedules, you have rituals, you have schools are the best place to bring these things in because the environments are naturally shaped for this.
Mhm.
So just making it part of your classroom culture,
Mhm.
to me, it just seems like the most efficient way to do it. And then from there, I've had many good teachers, really high quality teachers, share a homework rubric for home. And they practice it before the end of the day. This is how I want you to do your homework when you're at home. And they give them the breakdown and the rubric, and then they give it to the parent. And it's like, okay. I mean, there's something to be said there. It's if there's not enough opportunity for teachers to do what they're gifted at
Mhm.
because of the demands of their environments.
Yep.
And I think that what we're speaking to right now, I don't want to come off as Pollyannish here. I've been in I've been in schools that are 99% free and reduced lunch, trying desperately to just feed our kids, get them clothed in school,
Yep.
and keep them from whacking the crud out of each other. So I don't have any illusions about what school is, but I definitely think there are ways to bring the gifts of what teachers have to offer their kids into a structure that can be lifelong,
Yep.
not curriculum based, not 1 year episodes of success and failure in alternating form. You know.
Yeah, absolutely. Um, well, for example, somebody asked, do you think an executive function coach is good for a kid with ADHD? I know we had lots of opportunities here at Hill for, students to come in for classes for middle and high school students to come in and get that, 8-to-1 sort of executive function situation and really apply it right then in the moment. But I think
Mhm.
one of the bigger mistakes that I often see people make is trying to throw everything at the wall at once instead of let's sit down, you and I,
Yeah.
and talk about. You mentioned anxiety. Somebody else has said the same thing. They get anxiety and it kind of paralyzes them and they don't get it done and there's more anxiety and you end up in this cycle.
Yeah.
Um, and I think the idea is let's pick the most pressing issue. What
Yeah.
do you feel like you would really like to work on? Just one thing that would really make an improvement, and let's focus there and then apply that strategy, commit to it, and then let's develop a plan for how we're going to do it. Um, and I think that certainly at middle and high school, you can involve the child in developing that plan and really owning that, as opposed to it saying from now on, you're going to do this, this, and this, you know,
Right.
and
Right.
they're going to tend to shut down, in that moment.
Without a doubt. And I think we can also, along those same lines, I think we can shape the experience of very young students in doing that as well, even if it's something along the lines of we're doing an organizational structure or technique with them, but they're picking the color of the sheet we're using, or they're choosing which images or which icons they're going to belong to them. Personalization is a precursor to choice making in your future plans. And I think you can't, that for me, that makes a lot of sense. Just kids, kids who feel engaged in their own process are much more likely to stay engaged in that process. But if
Right.
you're being carried along or force fed, it's not going to carry. It's not going to
Yeah.
work.
Yeah, or having somebody do it for you, which of course, as a mom, I get that. And I was absolutely, doing that myself for my kids. Again, that idea, if you see them struggling, you want that part to end. And
Yeah.
so, you jump in instead of teaching them and making them self-sufficient over time. It's just hard,
Yeah.
hard journey. Talk about, is there still such a thing as a diagnosis of ADD?
So it's ADD by itself is a misnomer. ADD is not the diagnosis that's in the manual. ADD is it's our informal way of saying someone has ADHD, primarily inattentive type.
Okay.
That's what ADD means. So if you said, "Oh, that would be me. I have ADD," according to that criterion. As a even the term, the acronym ADHD is a caricature of itself. It doesn't capture well what we're exactly talking about, and it's an imperfect thing. Just it's a tool, and they're blunt instruments. I mean, I guess that's how I have to put it. It's a
Yeah.
blunt instrument, but it's functional, and we can leverage it for benefiting our kids. So don't get stuck on it, but use it for how it suits you, and then put it away when it doesn't.
Yeah. Somebody mentioned, and I believe it's an author of books who used to directly serve folks, but now is writing books to try and sort of reach the masses, just for lack of capacity to serve all the
Mhm.
people that were coming their way. But it is called Medical Medium, and I
Mhm.
believe it's about cleansing and some recipes, food type situations that are meant to help with some chronic things, including ADHD.
Mhm.
Tell
So
me what you
I'm
know
not
about.
familiar with that specific title, but listen, we've talked for years about we can go all the way back to the 70s with the Feingold diet and talk about food dyes and preservatives. And the reality is this: if you want an organism, that your child is this organism and you want them to function at their best, then giving them healthy nutrition is going to be a great starting place for that. The challenge with talking about things like allergies and food sensitivities is that there really is only one good scientific way to evaluate a food sensitivity or an allergy. And nobody is going to want to do it. That's doing a full elimination diet, bringing
Mhm.
yourself down to the low or absent allergens, and over weeks of time, introducing in small form some of those foods. It is the only way. Because if I was to bring you to an allergist and they're doing the tests to see if there's a histamine reaction on your arm,
Mhm.
that doesn't mean you have an allergy per se, because you can respond with a histamine reaction to anything. If you're under stress, if you're not sleeping well, if you had a recent cold, you're much more susceptible to having histamine reactions.
Mhm.
So I think the reality here is, if you want to do the least over the top option here, feed your child give your child fruits and vegetables in season that are the closest things to fresh foods. Make sure that you buy the cleanest foods you can afford, whether it's making sure you're getting local food, local produce, local meats, and really just try to focus on making sure that the nutrition you provide your child is adequate fuel for them. In the grand scheme of things, I think there's a lot of attraction to looking for a magic answer to these things.
Yep.
And my experience personally, and again, I can't speak to that book. My experience personally is the energy, the time, the money that goes into that is extremely hard for people to justify and find the results they're seeking. For some people, more power to you. If you have the energy and you have the means and the wherewithal to do a process like that, I begrudge you nothing, but I don't think there are magical supplements, magical vitamins, or magic foods. I
Yeah.
think that just if your child's uncomfortable because the foods they're getting make them sick, they're not going to do most things well.
Yeah. Yeah.
You know?
Agreed. Thank you for that. Thank you for
Yeah.
that. Dr. Kahn, I cannot thank you enough for your presentation tonight. It was really great. Lots of kudos in the chat to you. This has been really helpful, and I think you've touched on so many things that people on this journey have heard and are trying to soak in and figure out. And what can I do for the student? What can I do for my child? So thank you so much for your time and engagement with us here at Hill.
Well,
Thank you
thank
to all
you.
the participants who stuck with us through the Q&A. Thank you all for being here. I put my email in the chat if I can be of help for following up further questions. Any information that I can provide from us here at Hill, I'm happy to do that. Again, lots of kudos still coming in, and a couple of questions still coming in. So thank you so much. We'll be sending out a link to the video recording of tonight, as well as the slides and resources that Dr. Kahn has provided. And thank you all again for being here. Good night.
Thanks so much, guys.